Okay, everyone, thank you. Welcome, everyone. Thanks for joining, everybody. We've got a number of visitors. Thanks for joining as well. Thanks, everyone, for coming to this HOSC meeting for Woking Borough Council. I think unless there's anything else I need to go through, I think we can rattle through the first few points on the agenda. Is there anything else I need to say? So first item is apologies. Do we have any apologies? There are no apologies. Thank you. Minutes of the previous meeting. Has anybody had the chance to read the minutes? Would anybody like to propose those as a true and fair record? Thank you, Beth. Would anybody like to second? Thank you, Rebecca. Do we need to vote on that? Can we have a show of hands for approving the minutes? That's unanimous. Thank you very much. Public question time, Madeline. No public questions. Member questions. No member questions. So the first item is the primary care network. I don't know if you would like to introduce that or.
Apologies, everyone. We've got some of the clinical directors from the primary care networks who've kindly agreed to join us. We sent them a request to basically let us know some of the challenges that they're facing. So we've got with us tonight Dr. Thomas from Twyford, Dr. Joshi from Woodley. I think I saw Dr. Kennedy from Wargrave. So I don't know who would like to go first in terms of putting your views about your particular area.
Rachel, do you want to start? And then I'll go next.
Yeah, I'm happy to. Hi, I'm Rachel Thomas. I'm a GP in Twyford, one of the partners, and I'm also the clinical director for Phoenix PCN, which includes Twyford and Loddon Vale. I mean, really, thank you for inviting me to come this evening, and my colleagues as well. It's a very tricky time at the moment for general practice, I think, as we're all quite aware. I think there's a lot of, sadly, dissatisfaction as it seems to come across in the kind of press. And unfortunately, GPs are working harder than ever. We're providing more appointments than we ever have done before. And all of that with a reduced workforce. We've had a lot of changes, as is everywhere in the health service, to be honest. But as I think the first port of call and the face of the NHS, I think for localities, we've come under considerable strain. I think we've continued to provide really brilliant service as far as I'm concerned under quite difficult circumstances. We have had difficulty in retaining staff. We've had a number of staff leave. We've had difficulty in recruiting staff, which I think is probably one of the biggest issues. Despite some fantastic hard work done by my colleagues to try and improve this, there just isn't, unfortunately, the workforce there. We've worked creatively, so whilst there isn't as many GPs as there has been historically, we, through the PCN and the ICB, we've created the new roles, that the ARRS roles, such as first contact physio and pharmacies. And all of that works really well. But of course, it's getting that message out to the patients as well, to the general public, which we try our best to do. But, it can still be pretty difficult when things change. It's about managing that change and that change in expectation and change in service. And that can be quite hard, really. For Phoenix specifically, one of the surgeries has lost a long time partner who was pretty much full time. So that's been really difficult to recruit, and we haven't yet replaced. One of the other surgeries have lost, for example, their pharmacy technician, who provided excellent support in the background to the clinicians, and all of those things come together to make it really difficult. But I think we try our best, and we've implemented new systems, like recent new telephone system, to try and make things more user friendly for our patients. and to improve the patient journey, which obviously is what we're all trying to do. And I think so far it's quite new for one of the surgeries, and the feedback's been really positive, but it does take time. And I think I'll stop there because I could go on all evening, but I'm sure my colleagues have probably got some really good points as well. Thank you.
Thanks, Rachel. I've got something that I'd like to share with you. I've got Madeline on standby in case my tech doesn't work. So just let me know if you can see this.
Looks like it's just come in. Yes, we can see that.
Brilliant. So my name's Rupa Joshi, and I'm here with my partner in crime, as we call ourselves, Jim Kennedy. So we're both joint clinical directors from Wokingham North. I'm based at Woodley, and Jim is based at Walgrave. And once I finish this presentation, I will pass over to Jim for any other thoughts. As just a bit about me, really, is that as well as being the managing partner at Woodley, I also am the workforce lead for Berkshire West Primary Care.
I don't know. Right now.
I don't think that.
And I also work at NHS England, helping and supporting practices with their access issues, and hands-on support going in through calls or face-to-face, and really finding out what the issues are. And I'm also chairing a workforce and estates group for NHS Confederation at the moment, and work facilitating GP retention, burnout in mid-career GPs. I run a programme which is in the evenings to try and support the retention of GPs. So in Wokingham North, we're really aware of all the challenges that we're facing at the moment, and try our best to support colleagues. We do have a number of projects which we've been kindly supported by the council on. So we have preventative streams, long-term conditions, acute care. And what we're really trying to do is get a grip on, through population health management, the prevalence of certain illnesses, our populations, and trying to tailor our resource, be it limited to those that are really in need. And we do really understand that it has been a firefighting because of the demands, the complexity in who's coming in, the growing elderly population, comorbidities, that we do recognise that we do need a preventative strategy as well as a firefighting acute care strategy, and help for all of our patients with long-term conditions. I'm very happy to share the slides. I won't go through everything in detail now, as I'm sure we've got limited time. What I have done is a bit of an analysis for you on how busy we actually are using some of the data sets that we've had through the 3 surgeries. So we've got approximate populations, and to give you an idea of the number of phone calls that our reception teams are taking. So on an average Monday, across the board, at Parkside, our largest practice, 1,277 calls come through on a Monday. And over the week, 2,950, and that's with our new telephony service. We can actually see how long the call waiting is, how many calls are coming through, how many are dropped. And myself at Woodley, 931 calls come through, and we've got 4 receptionists on the phones. And you can imagine, the influx of calls, 2,598 calls over the week, which is far more than we have ever had. We're pretty much dealing with about 10% of our patient population per week. So 10% of our patients will be calling for advice, calling for help, for one reason or another. So what we are trying to do is ask our patients who are not urgent for the day to use the online system to put their queries in writing. And what we try to do is use active signposting. So we are trying to make sure that that patient has the best possible journey and sees the right person at the right time. And as Rachel was talking about the additional roles reimbursement scheme, so we have many different clinicians, all with different skill sets, and we try and match them to the patient with what their needs and demands are. We also have care homes, so we have 38 residents for Parkside, 75 residents at Wargrave. All of those need rounds, all of those need care and attention. And at Woodley, we have 3 learning disability homes that we care for. And if you look at the bottom of the table, we have very few partners, and our locums are increasing. We've got salaried doctors, but it is really difficult, as Rachel said earlier, to recruit into these roles. There aren't many of us around anymore, the GPs. They're either locuming or not wanting to be partners, so the burden really falls on the partners. So in Wokingham North, we've looked at things like health and wellbeing teams, and we've got an extensive set, and we've recruited through the charity Involve, and so we work together, which has been a real godsend. Actually, we get a real look into what's going on in the communities. A pharmacy team, we've got acute care physicians, physicians associates, paramedics and physiotherapists to work alongside our GPs and nurses and healthcare assistants. And we've taken on a nursing associate because we recognise that our nurses are at that retirement age and we need to think about succession planning. So our current challenges, the sheer numbers of patients coming through, that increase in morbidities, the increase in ageing populations, the turnover of staff. We have had admin staff leaving because of the public sector pay and the cost of living crisis. It's understandable. Unfortunately, through the government, we are not getting any winter access funding this year, which we had subsequently previous for all the years that we've had, that I've been in practice. I've been here for 20 years now. The carers being overstretched, the difficulties with secondary care, with their waiting lists, we are then getting a lot more of the work that they were taking on. People are coming to us because they're on the waiting list. They need some kind of support. There needs to be some risk management in place as well, which we inevitably take on. The ambulance delays, NHS 111 putting patients through to us through the course of the day. The self-care, the public expectations. I think through COVID, people are much more anxious. They need more reassurance. They feel more vulnerable. And we also have huge numbers of children coming in with minor illness. And we have our estates problems where we do want to recruit these additional roles, but we unfortunately don't have the space for them. So on the left is things we're doing, trying to look at our analyses, asking patients to book online if they're not urgent, so that we can have a little bit of an extra time to signpost them, using that additional roles reimbursement, using the community pharmacy referral scheme, where we can email local pharmacies to see minor illness patients. And we're trying to streamline the preventative care work stream with the long-term condition management and the urgent care management. And we are working extensively with the council, with our voluntary sectors. But what we do still need is more information messaging out there through newsletters, social media posts, how to get the right people that you need for the problem that you've got. When do you go to A&E? When do you go to the pharmacy? When do you call 111? And really getting more self-care advice out there, which would be wonderful if that's something that you could help us with. It is difficult when people are anxious and worried that, you know, they go to who they trust, which is their GP surgery. But getting the messages out there that they may not necessarily see their GP, they may see some of the other skilled workers that we're working with at the moment in primary care. Strengthening social care, using more of our community servicing resource, and support with our digital and data would be very welcome. We aren't skilled, we don't have that expertise, and I think, you know, having better websites, having better signposting, that artificial intelligence would probably help, but getting those self-care messages out there, and working with more population health management. And also with the mental health in children and young people, working with nurseries about how to cope with fevers, temperatures in young children, and schools. So I'm going to stop sharing, and I'm just going to pass over to Jim Kennedy for any other thoughts.
Thanks, Rupa. So just to give you some comparators to kind of put this in context. The average number of contacts for a GP across the European Union varies between 25 and 30. The average significant contacts for a GP in our area, and these are also indicative of UK figures now, is between 65 and 75 per day. So we're working at double the pace of our European colleagues. The GP funding model historically has been based on between 3 to 4 patient contacts per head of population with a GP per year. Currently, locally, we're seeing, and we've done our own research on this, we're seeing 11.5 to 13.5 contacts per head of population per patient in the population per annum. The working day for a GP is now 12 to 14 hours minimum. So when you have GPs, as I am, who work 3 days a week, nominally less than full-time historically, I'm actually working a 40-hour week, and I'm doing other stuff on top of that. The question as to where is this demand coming from? It's coming from a multitude of sources. It's not any one source. It's an accumulation of incremental impacts from lots of different sources. So pandemic has had an impact in terms of delaying access to care. Therefore, people are sicker. Therefore, they're consulting their GP more while they're waiting to get access to secondary care. When they do get seen in secondary care, because they're sicker, they then take longer to recover. So they're seeing their GP more. Mental health has had a battering. People's resilience has had a battering. Clinical standards are quite rightly increasing, and we hold ourselves to higher standards. So we're doing more interventions to get patients to more testing targets than they had been previously. We have an aging population. Contrary to popular lore, immigration and cultural subgroups are not major drivers of workload. In fact, immigrant groups tend to be younger and overall relatively fitter and more likely to be in the working population. We're seeing a big impact now from cost of living crisis and from the stress and fear that that is inducing in people, and that has a direct effect on physical wellness. Our numbers of GPs overall in the UK has dropped consistently and steadily over the last number of years. And of those GPs, fewer of them are willing to go into 40 hours plus per week because the pace and the intensity of the work is too high, and it creates too much risk for those clinicians. If a clinician gets it wrong, their license is at risk, and their employment and their future is at risk as a result. So clinicians, many of them will choose not to work at that pace because they find it too risky. It's also deeply professionally unsatisfying, and that is driving people away from the profession. So we are seeing a dropout rate, a significant dropout rate in males and females in the 30, 40, 50 age group. Rates of dropout that were they in any other industry would have members of boards screaming for a solution. And that is being driven by this toxic work environment that we have. Now, we're doing lots of things to try and help that. And you heard the group in particular is doing work with mid-career GPs to try and help with burnout, etc. But it is a reality. We're also seeing a pension and employment situation that is driving secondary and primary care clinicians out of the profession, particularly when they get to their mid-50s onwards. The punitive taxation implications of working once your pension pot is full means that some of my colleagues are working for 1/3 or even less than a quarter of their nominal take-home pay. And that comes to a point where people say, look, I've done this for X number of years, I'm not going to keep doing it for this kind of lack of financial reward. So we could quite easily keep you occupied for a number of hours looking at the many and complex issues. There is no shortage of innovation in general practice. Just look at the range of healthcare professionals that we've been bringing into general practice, particularly over the last 4 or 5 years. It's phenomenal, but they need supervision. They need training up. They have, in many cases, great expertise, but it's limited to a particular specialized area. So they don't have the breadth and depth that a GP does have. So in a way, GPs are a kind of the Swiss Army knife of medicine. You know, we can do most things and do most things fairly well. But a lot of our colleagues don't have that adaptability to be able to go across. They also don't have the prescribing qualifications at present, although many are working towards those. So there is a shift in the way we deliver care. There's a shift in the range of professionals we use to deliver that care. And there's a growing realization by the communities we serve that that has some benefits for them as a community. But it still is a societal shift that takes time to accomplish.
I can't hear you.
Thank you. Dr. Sharma, did you want to add anything?
Hi, yes. You'll notice the clothing of Jim, Rupa, and myself. We're all in our scrubs. That's because we're all still working. I think that's the reality and paints a picture. I'm not going to add too much more to what Rupa and Jim have already said. I think they've outlined all the issues. I think you obviously have an understanding of some of the challenges. We've had, as a practice, 1,300 calls today, or more to the practice. As Jim said, I've dealt with about 60 things today. The challenge that I think the council and members could help support us with, I don't think you'll be able to help us necessarily with the complex cases, okay? Because I think we've got to see them, and it's important that we have phone lines, online consultations, any method possible for them to access us. But where I think the council and public health could help us far more is dealing with those patients who aren't particularly complex, who've got coughs, colds, sore throats, running noses, things that I think we're all used to getting in winter, but things that are clogging up general practice. Today, my colleagues and I have seen countless patients with those kind of symptoms. Nearly all of them didn't need a prescription of anything, just needed reassurance and advice, which could have happened in the comfort of their own home. If they knew when to seek help, then they wouldn't have probably come in, and then would have been freer to spend the time actually needed with those patients who really need to be seen. There's probably patients out there who haven't been seen today in the practice who could have been seen, who probably need to be seen. That's the reality. If we look at the consultation rates, Jim has alluded to some of that, but the highest growth area is amongst 20 to 40-year-olds during the pandemic, and those under 5. So it's not necessarily the over 75s or those with more care needs that are driving the growth in demand, although that's a factor. So my plea and my ask really is, can we get some help? Can we get some support with comms? And I'm sure myself and my colleagues here would be happy to help support that. But can we get some comms to really help drive the message around self-care? We've gone from being a nation of hardy folk who perhaps would see a doctor in certain situations only, to now having a sort of message of, you have any symptom, the first thing you need to do is to pick up the phone or get online to your GP. That's unsustainable, it's unmanageable, and it has to change. And we want your help to help us change that and be realistic about what the NHS can actually deliver. It's not just GP, it's the same in A&E. We can't afford, A&E is far too expensive to have people in there with minor illnesses, which could have been managed at home. And we're seeing that in droves. At least 25% of what's come through the door today could have managed at home, and it'll be the same in every A&E as well. So that's my plea. I'm happy to help support it. I'm sure my colleagues are, but can we get some comms? And I'd like the councillors personally support this. If we can get John Redwood support to support this, but we need all the media that we have. Facebook groups, we've got obviously Health Watch, I can see here, we've got newsletters, we've got the emails that go from the council to almost every resident. You have an amazing reach that we don't have individually in general practice. So we'd love to be able to utilise that and to work with you to ensure that patients really know where they've got to seek help and advice from over this winter and where they can manage themselves. We have to support them to manage themselves and encourage them not to come in to seek advice when they don't necessarily need to. That's all I'd say. Thank you.
Thank you very much. I think it's been a really enlightening few minutes from all of you. I would encourage the councillors to ask questions at this point. Sorry, Phil, do you want to start?
Yeah, sure. Good evening all. Thank you for giving up your time this evening, some of whom will know me already. I wanted to first ask if you would want us to pass on a message. Who is going to put that message together in a simple, short format that we can pass on to our residents? Because we're very happy to do so. Secondly, I haven't heard yet, but what part does 111 have to play to assist you, and how does it need to change? And thirdly, is there any additional top-up support available from external providers like Westcall or something like that in hours, perhaps, that you could potentially draw on? Thank you, and good to see you.
Yeah, thanks, Phil. Colleagues may want to jump in on some of those, but I'll just perhaps answer the question about the messaging. So just on messaging, I think happy for us to, I think between us we could come up with something relatively quickly, simple, straightforward messages that could go out to all the residents. We've always found that videos have been helpful, and in the past we've certainly done those and utilised those, and I think several of us have, certainly myself and Rupert have done that, so we could certainly help support that. So I'm more than happy to do that, Phil, and work as a group on that one. On the issue around external support, so I think Westcall has similar challenges. If I'm being honest, they're working to the absolute maximum as well. I don't think there is any capacity. We've asked before. I think we've also got a problem this year, last year, where we had some funding and support nationally, and also some funding and support locally, which was agreed within the what was the CCG at the time. We don't have access to either of those particularly. We've got a much smaller, when I say smaller, very little funding at all this year to help support winter, and certainly nothing in the way of locally. We're trying to address that. We'll be making a case for it, but that is a big factor here. So last year we were able to provide a lot of extra appointments and get extra locums in and people doing extra hours, and we were giving some funding. We don't have that this year. So that is a big factor. And one of the things that I think is keeping us up at night is wondering how on earth we're going to get through the next few months without that level of support. And I've forgotten the other question, Phil, but Jim is coming in, so he can maybe answer it.
Yeah, so just in addition to what Ahmed said, NHS 111, it has its pluses and its minuses. There is no doubt that strategically we need some kind of system like NHS 111 that can take large volume public inquiries. The issues we have is that some of their algorithms are very risk averse and drive a lot more business into accident emergency in the ambulance service and general practice than would be ideal. And certainly where those algorithms have been refined in some small areas, it's managed to reduce that secondary dispersal quite significantly. It also creates an environment where people expect a kind of Amazon type service. You know, I have a pain for the last 10 minutes, I'm going to ring NHS 111 and I expect an immediate response. Now, you know, that is not a good thing necessarily in healthcare. It's good to have urgent responses to serious things, but not to non-serious things. So that whole culture of heightened societal expectations of the speed of response is creating tensions. The issue with Westcall and with any other services, we're all fishing in the same pool. There just are not enough clinicians of any type, and particularly GP clinicians. And if we end up in a bidding war with each other, it's just accentuating the problems we have with our delivery models. In our delivery model across the NHS, general practice is a major risk sink for the entire system. So we accept and manage risk in general practice. The more we have parts of the primary care system that are risk averse, the more it drives workload into much more high cost, limited capacity services, so accident, emergency, etc. Remember that the numbers that go through accident and emergency in a day at Royal Berks are less than the numbers that go through a medium-sized general practice. So more people will go through Brookside and Amit's practice in a day than will go through accident emergency. So you don't need much of a change in 50 general practices to create a huge knock-on effect in a place like accident emergency.
Thank you, Jim. I just wanted to introduce Ingrid. I think Ingrid had a hand up first.
Thank you, Chair. Evening all. And evening to thank you for our PCN clinical directors who've joined us. Nice to see you. I just wanted to reassure councillors and indeed our clinical director friends that we work closely together through the Integration Partnership Board, and we've had a discussion around some of these issues in that board and have heard loud and clear around that messaging and the comms support required. And we do have a comms post that has been approved, and we're currently out to recruitment for a specific health and wellbeing comms post within the local authority to specifically try and address and support our primary care colleagues around some of those messaging. So I'm hoping that the advert closes this week, and I'm hoping that we'll be able to onboard that person as quickly as possible, and then start to make some inroads in some of that messaging, working with you all across the next few weeks and months.
Thanks a lot, Ingrid. I think it was Rupa next, please.
I just really wanted to pick up on what Ingrid said. We have been really, working really closely with Ingrid's team, Lewis's team, Joe Parker. They've been a tremendous support to us. Joe's actually part of our video group clinic team, and she's really helped us with comms thus far, particularly with our preventative work, and Anna Thompson as well with data and PHM. So we have had enormous support. I was also going to just touch on the 111 issue. Us in primary care, we do actually, take on 90% of all consultations across the NHS. We're incredible value for money. We did have 111 come and visit our practice at Woodley, and they did an analysis, and for our Monday morning, they decided that they would need 20 call handlers to actually be able to sustain the amount of work that we get through with our 4 call handlers. and we train our teams, to the highest standard. So I think in terms of resource, we do provide the best value for money, and I think particularly what Jim was saying about the A&E. So if we can resource primary care as best we can and get the messages out there, I think that is the answer to the rest of the system.
I think it's Anil next, please.
Yeah, just to come back on Ingrid's piece, just around comms briefly. Ingrid, I think it's great, obviously, about the comms post, and no doubt you and the rest of the public health team and the integration board have helped support a lot of the comms messages. I just think we've got to get on it now because time is of the essence. I think if you look at the last 3 weeks, we've seen a real spike in demand, and so we winter is here. It's not coming, it's here. And the struggles, everyone's getting sick. We've got the first winter post pandemic and any sort of restriction, and respiratory RSV is prominent in the community. So I think we've got to do it now. We've got some resource in the Royal Berks and /ICB joint resource. So you've got a comms team there. They've got 6 people in that team, which is double what they had last year. So we've got to utilize that, as well as doing whatever we want locally, and they'll be happy to support, I'm sure. But we should be utilizing, I think, if we need videos recorded or we haven't got that facility or whatever function we're lacking, we should look to resource it there and make use of it and get this done quickly, because we just can't afford to wait.
I think it's Councillor Margetts next.
Thank you. Good evening. You touched on this a little bit, actually. Something you mentioned was about, obviously, people that are unwell for longer because they're not receiving treatment. I'm thinking of those people that are on waiting lists, waiting for surgery, chronic pain, orthopedic patients, those sorts of things that really must be impacting you, those people that are waiting, over 12 months for a hip replacement, knee replacement, etc., etc. So are you seeing any movement yet with the waiting list? Is that starting to improve? And how are you managing that? Because it was interesting to hear you say that it's the 20 to 40-year-olds that you've seen a real spike in, and it's these old, unfortunately for all of us older ones, that are kind of waiting longer for procedures that will keep us going for another few years. So how are you seeing that moving forward?
Amit may be able to give you specific figures for the ICB, but certainly locally I would take my hat off to the Royal Berks. I think they've been particularly good throughout COVID, and they have got up to speed in a more kind of sensible manner than most hospitals and secondary care systems that I'm aware of. So, full marks to them. But they've got a tired workforce just like us. They're still coping with the same patients we're coping with, and they're seeing the same kind of huge increase in demand that we're seeing. So I think as a system, we share this problem. It's a problem we're not going to solve in a year. It's going to take several years to solve it. I think locally there's good joint working across primary and secondary care, and with our social care colleagues as well. There's always bits that we could do a bit better, but I think there's a good willingness here, and there's generally good relations between primary and secondary care colleagues. So I think if anybody can sort it, we can. But the issue we have is a system that was already running at 98, 99% capacity and is now trying to run at more than 100% capacity. And when systems are running at that kind of level of demand and capacity, they become less efficient because there's absolutely no wiggle room in the system. And therefore, any small knock, like a surge in respiratory conditions or a problem with norovirus or something, has proportionately a much bigger effect because there's no spare capacity in the system whatsoever.
Thank you, Jim. I think Sarah has had a hand up a few times. Do you want to say something, Sarah, or not?
Yeah, thank you. So I'm Sarah Webster, the Exec Director for Berkshire West on the Integrated Care Board. There's quite a lot I could come in on, but there are two specifics I wanted to point out around the comms. Absolutely, we'll offer that support through our comms team, working with Ingrid and Amit and colleagues to get those messages out through the right routes. And then just on the point around the elective waiting list, I think Jim's answered that question, but absolutely there's a process within the Royal Berkshire where they're kind of looking at the waiting list at a patient level, based on the level of risk for each individual patient, to understand how they can manage that risk whilst they're on their waiting lists. And I'd echo the comments about the really strong working links between primary and secondary care on the elective pathways, and locally within Berkshire West. We are quite a strong performer when it comes to elective waiting times, although clearly not where we'd want them to be. And so a lot of work is still ongoing. And that's something, a focus of the Integrated Care Board as well, as to how potentially working with colleagues at Oxford and Buckinghamshire as well, we can speed up access to elective services.
Rupa, would you like to go next?
Yes, it's just about the close working really between the local trust and the GP surgeries. We've been part of pilots to try and tackle the waiting lists, and we've been giving group clinic support to patients on the waiting list for knee operations, on the waiting list for long COVID, and we're just about to start a pilot to help with orthopaedic waiting lists again, with the help of one of the consultant anaesthetists who's been working closely with us. So yes, I've got no concerns about that, and our patients were very anxious through the pandemic. They hadn't heard when they were going to be seen, but actually there's been a real step up. And we also have a liaison officer who comes out and does outreach with primary care and really bridges that interface. So no concerns, and we are really working very well together.
We're even sharing clinical staff now, increasingly, where we're developing new staff professional groups like physicians associates, where they do part of their week in the hospital and part out in general practice. So that's a very real and concrete crossing of the interface.
And I'll echo that for mental health practitioners as well, through the community trust, working within primary care and bridging that gap.
I'd like to go to Anil next, please.
Amit, yes, hi.
Sorry, Amit, I can't see.
No,
I'm going
right,
blind. I need to go see a doctor, I think.
That's all right. Oh, don't go to see a GP. And so, no, just quickly about the Royal Berks. They are also bringing in a service which will allow patients to be able to see the waiting times, indicative waiting times for each specialty, and also, clearer messaging about what to do if things worsen in the meantime, and in terms of the threshold that's needed for when to see your GP. Because obviously, as I think Councillor suggested there, one of the issues is, of course, while people are waiting, they feel more unwell, or they may experience a bit more pain, for instance, and so then end up seeing the GP. And sometimes that is appropriate. Sometimes there's other things that potentially could be done, or people could do themselves to manage it. So that's also ongoing and should hopefully be live in the next month or two, I understand.
Thank you for that update. And Councillor Croy, please.
Thank you. And again, thank you all very much for coming in this evening. I think my two questions are for Jim. Jim, you mentioned, I think at the beginning of your presentation, there was a comparison, and you said that the average in Europe was 35, I think it was contacts per day per GP, and that in this area it was 65. I was just wondering if you have the numbers for the wider southeast and for, say, England, just as a comparison. That's the first question. And then the second one is a lot of the sort of popular press coverage of GPs has been around the issue of face-to-face consultations or not, and my instinct is always to, I think, trust my GP. And on the one hand, I have GPs saying we need to do as much online as possible. On the other hand, we've got
the sorts of papers that I don't normally read, campaigning for as many face-to-face consultations as possible. And I would just like you to comment on how, just to perhaps shed some light on that whole debate from, again, people that I would love to hear from people I trust on that issue.
Right, and so on the two things, the figures for European comparators is from the European Association of General Practice, and a survey was carried out about 9 to 12 months ago by one of the UK representatives. The indicative figures for European comparators, and that's across the European Union, but also some non-European Union countries, is 25 to 30 patient contacts per day. So the figures we have for our local areas, Bucks, Berks and Oxfordshire, these are figures collated over the last 18 months on ongoing analysis of consultation data from GP practices by the local medical committee. And that's the figure of 60 to 70 consultations per day. Now, a consultation, some of them are going to be virtual, some of them will be telephone-based, some of them will be face-to-face. That brings us on to the next part of your question, which is the types of consultations. Now, every GP practice I'm aware of in this area is offering a buffet of different types of consultations. So patients can pick a telephone consultation or a face-to-face, and we're still doing home visits as well, and we're still doing nursing home visits. But we will try and help guide people to the most appropriate type of consultation for them and with the most appropriate type of clinician. It's an absolute waste of time coming to see me about anything to do with a dressing on a wound. My nursing colleagues are oodles better at dealing with that than I am. Equally, if it's a complex mental health issue, we have an outstanding mental health practitioner who we share with the Mental Health Trust. And for really complex mental health issues, she has some definite skill sets that surpass anything I have. So being guided to those or to a physiotherapist, etc., can get you to the right person for your particular problem as quickly as possible. But it means we need to ask more questions up front. It means the receptionists, who are now more care guiders, will ask some questions to try and get a sense of what would work best for that patient. But there is, or at least there was, in certain parts of the media, a very strong push for face-to-face consultations, even in the middle of a pandemic, when such face-to-face consultations increase the risk for both the patient and the clinician, and therefore could take out a clinician for several weeks if they got COVID. But a lot of patients actually quite like the convenience of telephone-based or video-based consultations. You know, not having to get 4 kids in a car and drag them down to our waiting room to wait for 10 or 15 minutes to come in to see us is quite a boon for a lot of people. Not having to leave work to come to see us face to face. And if a consultation starts, be it online or on the telephone or in a video consultation, and we think we need to put hands on somebody, we will, of course, convert it into face-to-face. Usually within an hour or two, they'll be down here and being seen.
Thank you. So thank you very much for that, especially for the second part. I mean, going back to the first part of the question about with the numbers, do you have comparators for the broader southeast? Because I think
I can't give you definitive answers with the same level of rigor that we have for our BBO LMC figures, but preliminary work that's been done using similar methodology in other areas such as Cambridgeshire and some of the Cornwall and Devon area suggests that they are on the same kind of figures.
Okay. Any further questions from any councillors? All you guys look super busy, so I'm going to leave you to go back to your practices. And a huge thank you for sharing with us. I think, we need to follow up on these activities, clearly. So I'm going to follow up with Ingrid and around comms, etc. But hopefully we can, I would say, broaden and deepen the relationship. And I think if we have a comms lead here, then that will help the councillors distribute the right information, because health is such an important matter. We must make sure that the information we share is absolutely rock solid and the correct information pertinent to that time of year and everything else, as Dr. Sharma and everybody else has spoken about. But a huge thank you from this committee, and we hope to see you again, and we hope to see you with less issues than you had. And Rupert, what an outstanding presentation. Thank you for that. That's one of the best presentations this committee has received, both in detail and in breadth and depth. Thank you very much for that.
Thanks,
sorry,
everybody.
there's one question from Andy.
It's a question for you, actually, Chair. So in the light of the urgency which was emphasised by, I think, Amit earlier as part of his presentation, and the amount of time it can take the council to onboard new people, however valuable they are, can I also suggest that you, as chair of this committee, get hold of Sarah Kerr, who's the lead member for comms and perhaps the lead officer for comms, and try and do something with an aim to get something out this week? There must be something we can do, as Annette has asked for, immediately, rather than waiting for the onboarding of that specialist.
I'm not sure Sarah Kerr will be able to add to this specifically, but I'll take this up with Ingrid, definitely. I know she is, but this is health comms, which is, it has to be expert, right? So I don't want this put into a general pool of comms.
I'm sure something can be done very urgently.
Yeah, but I will reach out to Ingrid this week. Thank you. Thank you very much, everyone, for your time.
Thank you.
Sarah, I think we move on to your agenda item, which is integrated care strategy. So I will leave you to talk. And if it's okay with we would like to ask you some questions at the end of your presentation.
Yeah, thank you very much, Chair. Absolutely. And I'll also introduce my colleague, Rob Bowen, as well, who's our Deputy Director of Strategy at the ICB. And so he'll help me with the presentation and some questions as well. So just to reintroduce myself, I'm Sarah Webster, the Executive Director for Berkshire West on the ICB team, the executive team. I'm relatively new in post. I've been here a month, and so have been doing an awful lot of sort of introductory meetings, listening and getting out and about, meeting everyone across the patch. Prior to this role, I worked at the Royal Berkshire as a Director of Operations, and I actually live in Wokingham, so I'm relatively familiar and local to the patch, but still learning a lot. I won't talk through the presentation slide by slide because I appreciate everyone's had it in advance, but I thought it would just be helpful to do a little bit of scene setting to try and bust through some of the acronyms that we love in the NHS, and just to establish the understanding of where we are currently following the restructure that we've been through recently organisationally as an NHS. And then Rob will go on to touch on the ICP strategy development. So first of all, just to reiterate to councillors that what I'll describe as the frontline NHS organisations, locally being the Royal Berkshire NHS Foundation Trust and Berkshire Healthcare, haven't changed. So the change in structure is more around the kind of the planning and commissioning organisations that used to be the 3 CCGs across Berkshire, West, Oxfordshire and Buckinghamshire. And we are now one integrated care board, which is the statutory NHS organisation that now covers a larger footprint. When we talk about the integrated care system, that is the geographical footprint across Berkshire West, Oxfordshire and Buckinghamshire. And within that, there are the two statutory entities. So there's the Integrated Care Board, which is the largely NHS statutory entity with local authority input. And then there's the Integrated Care Partnership, which is a statutory board that brings together the Integrated Care Board along with representatives from the 5 local authorities across the BOB geography. And that is the key strategic board. And it's a great development because it's bringing together under a statutory entity, NHS and social care, to really work together in partnership to plan for health and care services with a real focus on prevention. So we've heard from colleagues now around the challenges that primary care are facing and the opportunities that then provides us to address some of those coming together as a partnership. Locally, what that means for Berkshire West. So we are what we now call a place. And that is the kind of the local focus within the integrated care system. So within the Berkshire West place, there's the 3 local authority areas, Wokingham, Reading and West Berkshire. And this isn't new to us working in partnership across this footprint. We've got a strong history of coming together as organisations from health and social care perspective to work together within the Berkshire West footprint. But what the latest changes give us the opportunity to is to come together and think, how can we take this further together? How can we formalise some of the joint working that we've been doing thus far? How can we refresh our priorities? And importantly, how can we really make sure we are having that focus on prevention together so that we can address some of the issues that we're currently all fighting right now in a more strategic way? So it's quite an exciting time, and we've had some meetings recently joining together of the chief executives across the patch. So Susan Parsonage was there just last week, and it was really quite invigorating, actually. We left feeling really optimistic about the opportunities that we're all going to have coming together as system partners. So we're looking forward to seeing how this partnership can develop and where this might take us, where if we truly pool efforts and resources and focusing on key areas of and key pathways that intersect all of our organisations, be it primary care, social care, health, voluntary sector, how can we really make a difference for the residents that live in our patch? And that's the most important thing, and we can't lose focus of that. So that's a bit of scene setting. I'll hand over to my colleague Rob now, who's going to talk a little bit about the work that's been going on around developing the broader strategy for the Integrated Care Partnership. And other colleagues on the call, such as Ingrid, might want to hop in as well, because I know it's been an awful lot of joint involvement in this. So I'll hand over to Rob. Thank you.
Thank you, Sarah. So hello, everybody. My name's Rob. As Sarah said, I'm part of the strategy team at the ICB. But importantly, I think I'm here talking about the strategy on behalf of the wider partnership that's working on behalf of local authorities and the ICB. So really talking about work that we've been doing on behalf of that partnership. Again, I'm not going to talk through all of the slides in detail, but just give a very brief overview of the process that we've been through to develop some of the priorities that are emerging, and then talk a little bit about what we're expecting to see over the next couple of weeks and how we're expecting to more formally engage with local authorities, health and wellbeing boards and the public. So in terms of a little bit of history of how we've got to where we are now, we started back in July when it was clear that there was going to be a strategy that was developed on behalf of the whole system by looking at what were some of the existing strategies or ambitions or plans that were already in place across the whole of the system. A really important input from that perspective was trying to understand what the health and wellbeing strategies were, but also understanding a bit more about what some of the NHS organisations' ambitions were, and then trying to think about how can we identify where there are potentially common themes that we might want to pick up and understand and dig into in a bit more detail from a strategic perspective. That led to the development of the working groups. Again, there was a slide that we put in the material about that. So we had 6 working groups that were established from September. Those working groups were set up deliberately mostly with a local authority officer who was responsible for sort of leading and shaping some of those conversations. But the membership of those groups, importantly, was trying to be as diverse as possible, representing the partnership. So we've had officers from local authorities, we've had people who've got all sorts of different professional backgrounds. We've had NHS organisations, we've had primary care colleagues, we've had voluntary sector colleagues, we've had Health Watch colleagues contributing to those different conversations. So those conversations have been rich, and through those conversations, we've started to identify a number of different priorities. Those priorities are still being defined through those working groups. But I think there are some, it's important just to touch on some themes that are starting to come through. There's a really, really strong message that's come through about prevention, and the need for us collectively across the system to do more in terms of trying to move the dial to be more prevention focused in terms of how we work and support with people across the whole of the Bob patch. Another is trying to think about where we've got disparities across our different populations and communities, and understand what we can do to support those different communities where some outcomes are not as good as others. Try and bring those up to a point where we've got a better set of outcomes across the whole of the system. There's also a theme coming through around making sure that we are local in how we are thinking about how some of these services are going to be delivered and designed. All the way through this and through the national guidance, there's been a real clear message that health and wellbeing boards and what we do at place level will continue to be very, very important, and what's being developed through the strategy is not meant to replace that, but actually in many ways strengthen that. And then there are some messages coming through about actually how we can be more joined up across the different different bits of our system. So those are some of the themes that are coming through. In terms of the next steps and just trying to look forward, initially when we started this work, we were expecting to publish a strategy at the end of December. But as we got closer to that date, we have started to realise that we're not going to have enough time to meaningfully engage with our populations, to engage with our partner organisations properly. And so what we've done, we agreed with the partnership group that met at the end of October. That group agreed that what we would do is that we would actually build into our timeline a 8, 9, possibly 10-week period of formal engagement that will start at the end of this month. And that will look at some of the priorities that are emerging and seek formal feedback and views and opinions on what those priorities are. And that will then culminate in a publication of the strategy. It's looking like at the end of February. So the aspiration is that we continue to be kind of open and in seeking views and opinions as we're going through that. Hopefully that picks up some of the things that you wanted to hear about, but we're really open to further questions or comments that people might have about how things are going and what we've got in the material.
Rebecca?
Try not to be negative here about your health promotion issues. They're nothing new, are they? They're without being slightly depressing. You know, obesity, smoking, alcohol. These are things that, you know, we've all known about for years. So what new initiatives are you looking at bringing forward to try and tackle these issues? Because, you know, we haven't been hugely successful so far, have we? Kind of nationally. I'm not saying locally, but, you know, they are big issues. and they are the things that are clogging up doctors because of the, doctor surgeries we just talked about, because of the, needing a joint replacement because you're overweight, because of the strain it's put on your joints. So, there's lots of things that come into this. So, yeah, what are your new initiatives going to be? Do you have any? What's new?
So I'm not going to answer your question directly because I think Ingrid will do that. But I think you are highlighting why this needs to be something that we continue to prioritize through the strategy as we look across the whole of the system. So these are issues that do affect people's daily lives. They affect people's health. They impact on other parts of the system. So really important that we continue to focus on them. But this was one of the areas that Ingrid has been really involved in developing and having the conversations around. So Ingrid.
Thank you.
Yeah, please go ahead, Ingrid.
Thank you, Chair. I was the chair for this working group, and I think you're absolutely right. I think councillors will find across the strategy as it comes out for consultation, and it's still not, I don't think, firm up in terms of the priorities, but there are not going to be huge surprises in terms of the priorities, and I think that's probably a good thing, because what we're trying to do is draw together priorities that already exist across the broader geography, but then to try and see what might be tackled at scale or what might be tackled more efficiently locally. So trying to draw out those two kind of ends of the scale around those common priorities, but also then looking at what we might do differently. So I completely agree. And one of the first things that we did in our workshop was say, it is a depressing subject to keep revisiting. Rob was in that discussion, obesity, to keep revisiting, smoking, how do we bring that together and say, right, actually, health behaviours cluster together. Let's not address smoking cessation with leaflets in the foyer of the hospital. Let's think about how we might more meaningfully address clustered or poor health behaviours within our populations, whichever populations those might be. So those conversations are very definitely happening. What the action looks like that falls out from that is part of the ongoing conversation. That's the bit that we're in at the moment in order to get into the strategy for the consultation. But I do think there is some innovative thinking in there, certainly in our area. And I do think that even beyond that, so we did our work stream, and then as that's gone back with some of the innovative ideas, people have started to pull across some of that health behaviour work, the health promotion work across the whole strategy, so into all of those other areas. So starting well, living well, ageing well, and actually pulling those across rather than having them as standalone. So I realise that's not got any specifics in terms of actions that we might deliver, but we are thinking about it in that innovative way and not in the traditional way that we might have thought about it before. So I hope that it offers some reassurance that's happening.
Thanks for that, Ingrid. Councillor Rochelle Shepherd-Debay.
On one particular point, live well. The third point down, you said increase cancer screening and early diagnosis rates with particular focus on addressing inequalities in access and outcomes. Why aren't you X-raying? Why aren't you having breast X-rays on women over a certain age? You seem to stop it at a certain age. Do women not get breast cancer after they hit 50 or 55 or 60? Why are you doing that?
Are you asking why that's in Live Well and not in the others?
Why in particular, in that particular case, you're saying that you're trying to increase cancer screenings, but you're not actually doing it for women's breast exams over a certain age? So
the specifics of us. So in terms of the intention of the strategy and the themes that are coming through. So firstly, the priorities that we got here are very much draft, so we're still developing them. Secondly, in terms of some of the things that are coming through through those life stage focused discussions, they very much do go across more than one life stage. So the fact that we've had the conversation in Live Well, and at the moment the theme is picked up in Live Well, doesn't mean that it's only relevant to that particular stage in life. It's just where we've captured it as part of our conversation. I don't know if there's a clinical question that we need to address, Ingrid. I don't know if that's something that you can help with or not, but.
Absolutely, Cancer. So in terms of the breast cancer screening programme, we would only be able to follow the national breast cancer screening programme within the local area. So we wouldn't be able to go outside of the national programme, and that does stop at a certain upper age limit, which is perhaps another discussion.
My question is, why are they doing that? It just doesn't make any sense that women still get breast cancer at later ages, but they're not being tested for it. It seems to be out of keeping with that particular idea of increasing. Rather, it seems to be decreasing, not increasing.
Right. So I think that,
it may be a national program, but it still is a question about why is that happening. That's all.
Yeah, no. So I take that. So the national screening programme has its is funded by NHS England and has its own parameters based on the evidence available to them, reviewed by NICE, and the guidance set out within that national screening programme. The idea locally, or the idea behind the strategic priority of increasing or maximising uptake of screening, is within those national guidelines, but there is good evidence that screening has fallen across COVID, across all of screening programmes, and is also particularly screening programmes are particularly affected is the wrong word, but underpin health inequalities. So we know that actually ethnic minority communities or communities in socioeconomically deprived areas access their screening programmes less than other residents. But not only that, but they've also been further dissuaded from screening as a result of the COVID pandemic. So that disproportionate, that health inequality has widened across COVID and needs to be a priority in terms of driving that uptake back up, albeit within the perhaps paradoxical confines of the national screening programme, which is based upon an extensive set of evidence. But I can understand how it seems to not make a great deal of sense in that age profile.
I'm just curious to see, can you give me the technical reason? Can you get the technical reasons for that? I'd like to ask, are they doing the same thing with men for testicular cancer or something like this, or is it only women that are not being screened at a certain point?
So there's no national screening programme for testicular cancer, but I can absolutely get you the evidence for why there is an upper age cutoff for the national screening programme for breast cancer.
Thank you.
Bill?
Yes, good evening all. To bring you back into Wokingham, which is the borough council that we're talking from, what does what Rob and to a degree Sarah has presented, what does that mean for Wokingham? Because obviously within the borough council we've been working on putting our priorities together. Do they necessarily have the same priorities in the other areas which are within Berkshire West, and how do we align those things in order to make sure that each of the areas is having focus on the things that the local authority have identified for their residents?
So I'll come on this first, and then Rob and Ingrid might want to comment as well. So I think first of all, it's really important to reiterate that the local health and wellbeing strategy across the Wokingham, Reading and West Berkshire is still absolutely key in focusing on where we feel we need to prioritise. That has informed the integrated care partnership strategy, and so the two are complementary. So clearly the voice of Wokingham and Wokingham residents is very, very strong and a core part of the local health and wellbeing strategy. The priorities are similar, but as you know, the three different local authority areas have different pressures and different challenges. And one of the focuses of as we're developing the local place partnership, is making sure that we don't lose those nuances and that we are able to still personalise and focus the work we're doing within each local authority area to make sure we are targeting the areas that matter the most for the residents in each patch. So we are still forming what the partnership looks like, how the governance works, and how we make sure we're able to focus in the right areas. But I can provide the reassurance that that is absolutely key, and that is a success factor as we form what our partnership working is.
Alison Swaddle.
Thank you, and thank you for attending our meeting this evening. As Phil said, we need to bring this back to our residents here in Woking. That's why we're here tonight. And I think one of the things in your emergency priorities that we know is of the greatest significance is improving access to health services. We heard earlier this evening from our GPs it's very difficult because of increasing demand. And your bullet point 1 in 5 is develop stronger integrated neighbourhood teams. So I wondered if you could expand on how you're going to do that. Thank you.
So I can talk a little bit about some of the discussions that we've had, and I think that will fit with some of the comments that we heard from our GP colleagues earlier. But I think importantly, as we go through this process, these priorities are the emerging priorities. As we think about actually how we are going to address these things, part of the response will sit with system partners. So part of the response to the strategy will sit with the ICB or with NHS partners to think about actually how do they need to respond. And there is a formal sort of planning mechanism through which that is going to be done. So the ICB is at the moment starting a detailed planning piece of work which will look at some of the challenges, one of which will be around primary care and how do we continue to support our primary care colleagues with the various different pressures that we've heard about this evening. In terms of the specifics of the it's a bit jargony, the kind of stronger integrated neighbourhood teams, but essentially it's about trying to support primary care networks work as more than just a network of general practitioners. So it's trying to think about what are some of the other roles that we can bring into that wider team, and how can we start to bring in some of the other organizations or different bits of the system that can work jointly with GPs to provide a more comprehensive offer to people that need primary care support. So that might be looking at some of the roles that we heard about this afternoon, be they people that are supporting kind of navigation around the system, be it around kind of particular mental health support, be it around some of the other specialist roles that we can see developing there. But it's about trying to work with our primary care network colleagues to really build that as a comprehensive team as possible that is supportive of the work that our GPs are doing.
Yeah, one of the things they specifically mentioned was they really need additional support with digital and data. Mm-hmm. Is that something you'd be able to do?
So again, that is part of that will, firstly, part of that will come through as we get into the how will we make it happen bit of the strategy. So there will be a bit on data and digital. But I know that there are colleagues who are working as part of the ICB who are working really closely with GP colleagues across the whole of Berkshire, West Oxfordshire and Buckinghamshire about actually how can we make sure that we have really robust digital support for those practices, but also how do we work better to share data in a way that's going to allow people to identify those patients that need our support as in the most appropriate way that we can as quickly as possible.
Yeah, please go ahead, Phil.
Yeah, sorry. Thank you for putting up with another question from me. But with regard specifically, Sarah mentioned social care in a local environment, and I want to gain some assurance from you, even in your strategic position tonight, that initiatives to improve and to support social care and to enable people to live well without necessarily accessing primary care systems will continue to be supported in Wokingham, and the systems that are already in place will be supported to make sure that we maintain the level of service that we've been delivering to our local residents.
So there's absolutely a commitment to keep working together on this and make sure we are able to provide an incredibly robust social care service that is complementary to the healthcare services. I think we've got, so I've been working closely already with Matthew Pope, your Director of Adult Social Services, and already we're identifying areas that we think we can work together on to further improve. So I do want to give that absolute assurance to the committee that this is something that is of a joint priority and an area that we want to continue working on together, to make sure we can keep finding areas that we can improve on together.
Thank you. I just wanted to, Ingrid said earlier there were very solid reasons for things being similar to, as was previously described with the Wellbeing Board, in response to Rebecca Margette's. But post the pandemic, we have this, I would say, newer research into excess deaths. Is this a topic for the strategy as well, the excess deaths that are continuing post pandemic, or is this not on your radar?
So we have gone back to the information that's available to us through the JSNAs, and looked at some of the data that we've got there. So that has, as in Ingrid may be able to give a bit more detail on some of this, but we haven't specifically looked at kind of excess deaths in relation to COVID and some of the things that we see coming out of COVID. We have tried to understand actually how COVID has impacted some of the other impacts. So we in our Start Well working group, there's been a long conversation around how do we make sure that we are working again across the system in as joined up a way as possible to support those families where actually they have been impacted by not being able to access services, or children not being able to get the sort of usual social developmental opportunities that they might have had were it not for the national lockdowns that we've had. So the impact of COVID has been something that's been picked up by different working groups, and the impact that that's had on people's lives and the health of the health of different communities. But Ingrid may correct me, but the excess death point particularly, I don't think has come through specifically.
Sorry, Chair, my camera isn't following my instructions. Yeah, just to build on, so the excess deaths locally are, perhaps we should have more of a detailed response offline, Chair, but I'm not aware of a specific causal relationship between any excess deaths with either COVID or non-COVID related causes at the moment that has information that would be usefully fed into this 5-year strategy looking forward. So whilst there might be looking at individual cases and smaller numbers locally, that's not feeding into this broader strategy at this geography.
Thanks for that, Ingrid. One more question. I don't know if you know, what I hear every meeting I go to is recruitment and retention problems. I went to a meeting of the RBH Trust last week, and this was mentioned there. And one cause was doctors retiring because of these, I would call it an arbitrary pensions number that was determined by Theresa May 6 or 7 years ago, which is not linked to inflation at all, which is 1.073 million. And that was mentioned at that meeting as a cause for doctors retiring earlier. It was mentioned at this meeting for GPs retiring earlier and not coming back. Is anybody lobbying anybody to get this arbitrary made-up number from 6 years ago changed so that doctors can continue to work in the NHS and primary care systems, or is just everybody just leaving it?
I'll come in on that one. So I think this is an issue that is well known and understood, and is being discussed at certainly the highest levels in the Department of Health and Treasury, and I know certainly on the Secretary of State agenda as well. The outcomes of those conversations we don't know, but it is something that's absolutely on the radar, and I do acknowledge the impact that this is having and the risk that this causes for availability of senior clinicians, both locally and nationally. So you're right to highlight it as a key issue and a concern for consideration at the moment.
One more question, I think it's really for Sarah. Sarah confirmed that we would be trying to work together and trying to support the Woking residents in the ways of working that we were previously. One statement by the GPs was, and I would say the GPs sounded very disappointed, was there was no local CCG funding, winter funding, which they had in previous years. And that will not be carried forward to this year through the ICB. Is that correct?
So there's two elements to this. One was that there was some additional national winter funding that was made available that we've not had access to this year. So there's conversations happening at a national level around that. But at the moment, that funding has not flowed through to our system. The second element is that we had some funding available to support additional walk-in on-the-day primary care capacity. That money is funding a pilot urgent care centre to support the on-the-day demand, both from a walk-in perspective, but also where primary care and the emergency department can redirect patients into this primary care capacity that's going to be located quite close to the A&E department in Reading. To try and piloting this way of working to try and absorb some of the pressure that way. So the funding's available, it's being used slightly differently, and it's an 18-month pilot to see whether that has an impact on the day demand. And if it does, great. If it doesn't, then we're going to continue to review and can reshape what that service looks like.
Thank you, Sarah. I think we've got no further questions. Thank you very much, everybody, for your time. Hopefully, Madeline will organise a revisit once your strategy has gone through its consultation process and you have more information to share with us. We would really appreciate that you do that. Thank you so much for your time, and I wish you, from this committee, a very good evening. Thank you very much.
Thank you. And Chair, could I also just offer, I know there's been changes to kind of previously what would have been your links at the CCG as we've become the ICB. So if ever anyone has any questions or aren't sure who to turn to in the ICB, then I'd happily volunteer as the contact point for queries that I can then support you to take forwards.
Thank you very much, Sarah.
Thank you.
Thanks.
Bye-bye. Where are we up to, Madeline? Health Watch, mental health.
Sure, just to interrupt. At some point, do you think you can consider representation about the quality of the sound in here? Because actually it's been quite hard to hear what some of them have been saying. And whilst we think we've got the gist, we don't want to guess that we've got the gist.
I spoke to Andrew Moulton 2 weeks ago about the quality of sound in here. I asked him if we could potentially get meetings scheduled in the main hall, because for me, the audio is much better in there than it is in here. I don't know whether that's the same for you guys or not. But I always struggle with the audio in here. It's not good.
No, you're not. I'm just not making pressing. We could encourage our own officers in person. They used to. Sorry, can you press it? I would like to ask the chairman to encourage our own officers to come here in person to speak with us. I think, you know, we have always enabled guests and people from outside the council, but could we please perhaps encourage our own officers to come and attend?
Yes, we.
I did struggle with some of the sound myself.
I'm completely with you on the sound. I hate the sound in this room. Rochelle.
Couldn't we just buy a sound bar for the bottom and hang it on the bottom of the telly? And that might be better than we're getting right now, because it's coming from the telly, and the telly sound is great for a home, but not necessarily for a large area like this. And sound bar would be the easiest solution, like one under both of those. At least would give us better sound.
Yeah.
We don't have to we don't have to put sound. We don't have to spend, 50 million pounds on getting sound all around the place. A surround sound, just a sound bar, a couple £100 would be it.
So sorry to have intervened. No, it's fine. I'm a big fan of calling a spade, and I couldn't hear half of what Sarah was saying, or one or two of the other ones. My hearing is not perfect, but for me, this room is always problematic. I really hate this room. I never get good audio in here. So we will take away actions and come back with a proposal, either to do it in the council chamber or get somebody like Andrew and his technicians to review the technology or something.
Yeah, just to also say that the cameras aren't working correctly. They're not focusing on the right people. When Andy's speaking, it focuses on Lucienne. When you're speaking, it comes over here, So, I mean, we're not providing a good service for our residents watching on YouTube.
You're absolutely right. I couldn't agree with you more, Alison. I hate this room. I'd rather not be here.
At this point, when you're speaking, it's focusing on this side of the room.
I know. Right, can we concentrate on mind, please? Sorry. Mental health service, apologies. You can't see me because the cameras are in the wrong direction, but thank you for joining us this evening. And I would like to hand it over to Helen and Christine.
Can you see the screen?
Yes, we can.
So, sorry, our audio is not fantastic this side. So
Okay, I'll try and sit close to
if
my
you could speak
microphone
really
because I'll
loudly,
better.
if you could speak really loudly, we might be able to hear you.
Okay, I'll give it a go. Okay, so I've been asked to do an overview of the community mental health services in Wokingham. So I work in mental health services in Wokingham. I'm Christine Dale, so I'm for the local authority assistant director for integrated mental health, and for the trust I'm head of mental health. So I am in a joint role, and I manage the services on behalf of the NHS and the local authority and their integrated services. So the services I manage are the community mental health team for adults, the memory clinic in Wokingham, the community mental health team for older adults, the home treatment team for older adults, and the recovery college on behalf of Wokingham Borough Council. I have been around the council for quite a number of years, and a number of people know me, and I think some people led to believe that I am actually responsible for all the services in Wokingham, which is not the case. So I just wanted to outline what my responsibilities are. So in Berkshire, I've put this link up here because I thought it might be useful for you to consider further services that you might like to look in more depth in future as part of the committee. So the link is to the services that are provided by Berkshire Healthcare Trust which can be accessed by residents of Wokingham, and in that there are 40 different mental health services. So the link takes you through to a page of tiles which you can click on, and it describes the service. It gives you a link to the service behind that to explain the service and how it's managed and run. So some of the services are local community-based services like the ones that I manage. There are a range of specialist services like early intervention in psychosis, eating disorders, etc. There are hospital-based services in Prospect Park and in the Royal Berks. And there are also Berkshire-wide services, so like the crisis service, and there are also services that we share with other boroughs, such as the court divert services are Berkshire and Hampshire. So there are a range of services, and they're all on that link there for future reference. So as I said, I manage the community mental health team. Well, I'm responsible for that. I also have a service manager in charge of running the community mental health team. He is also in a joint post, so he also works for the trust and for the local authority as well. So our services are fully integrated health and social care services. So we manage staff such as medical staff, social workers, nurses, occupational therapists, support staff. So so there are a range of professionals within the service that we manage in one system. All referrals coming into the community mental health team come through common point of entry, or the gateway as it's now described. So they will triage all the referrals coming in, and they will pass the referrals which are appropriate for our service on to us. So the community mental health team for adults deals with people with severe and enduring mental health needs. So it's a higher end of the scale of need. So people having disorders or illnesses such as schizophrenia, bipolar personality disorder, for example. So as I said, because it's an integrated service, we've got a single access point, and we have single integrated processes under the joint management. This is not the same across the rest of the west of Berkshire, where the services, the health and social care services, are not integrated in the same way. So within this community mental health team, we have a psychological service staff and therapy staff who provide a range of psychological interventions and support. We have a carers worker. So we do carers assessments, and the majority of our carers have a direct payment for their services. And we also deal with assessing people under the Care Act for funded packages of care, and also work jointly with the ICB to jointly fund packages where people are entitled to health and social care support as a jointly funded care package. And we also do safeguarding for people open to us. One of the things I was just going to mention that we have achieved again recently, we've had it for the last 3 years and have just been awarded another 3 years, which is accreditation of the service with the Royal College of Psychiatry, which is an NHS kite mark of sort of standards of service really and quality. So we're very, very pleased with that, which adds to the kind of outstanding CQC rating for the trust overall. So that's been good news recently. One of the services I was asked to talk about, and I don't manage, is improving access to psychological therapy or talking therapies. So this service is actually managed by Alison Salvadori. So the service provides talking therapies, and they provide treatment for common mental health problems, as opposed to the severe and enduring that the CMHT do. So they would deal with people suffering from lower levels of depression, of stress, anxiety, or phobias, and they provide a range of things. So workshops and video courses for well-being and stress, guided self-help, online therapy via Silver Cloud, individual therapy such as CBT, counselling for depression or mindfulness. They also provide employment support, and they run their service on extended sessions until 8 p.m. 4 days a week, because they obviously have referrals from people who are working and who would need to be seen later on in the day. Okay. Crisis Resolution Home Treatment Team is another service I've been asked to talk about. So these slides have been put together by Colin Edwards, who's a colleague of mine who actually runs the crisis and home treatment teams across Berkshire. So that what they offer is a 24/7 immediate risk triage assessment by their duty team. There's been no reduction in the service that's they have been delivering through the pandemic. They've worked all the way through. The Crisis Resolution Home Treatment Team have been inflexible in their approach to the pandemic, as have other services. What they have seen in the services over the pandemic is an increase in problematic drug and alcohol use. Their workforce has remained consistent, and they feel that COVID has brought them more, not necessarily higher levels of referrals, although there has been some rise, but what we're seeing is far more complexity. And initially in the first wave of the pandemic, what we actually saw was an increased number of people with psychotic presentations, and often a number of people from professional backgrounds in that group. One of the issues for the service during the pandemic was a fear of job loss following, I don't know if you remember, but the NHS staff were sort of mandated to have the COVID vaccine, and there was directions to trusts to not continue to employ people who weren't compliant with that. And I think for my service, it wasn't too much of an issue, but I think it was obviously difficult for some of the staff in the crisis team. So they've also seen an increase of workload through reduced capacity of other services. So they have, under Colin also comes a psychological medicine service at the Royal Berkshire Hospital in Reading. So PMS have offered 24/7 face-to-face provision throughout. They've also offered telephone assessments. Since March 2022, the team have operated at full pre-pandemic levels. The demand for psychiatric beds remains high, which is higher than the expected norm, which is a theme across England, really. So that's not a particular thing for our area. There's been no reduction in the service that PMS have been offering. Core 24 is an assessment tool, so the response times have been consistently met, so they've been assessing and doing as they need to do, and their workforce has remained consistent throughout the pandemic. One of the other services that I am responsible for, and we developed it in 2020, was the Recovery College in Wokingham. So this is a prevention service, and it's open to residents and staff age 18 years plus. So the theme with the Recovery College is that we offer courses to people, but they are co-produced with service users, and they focus on improving their mental health and well-being. And the college aims to help people become experts in their own self-care and enable their family, friends and staff to better understand mental health. So the staff that we have in the Recovery College, except the college lead, are all staff who've got personal experience of mental health problems. So we would call them experts by experience. We deliver the courses all in community venues across the borough, local community centres, that kind of thing. And what we've been doing is working with developing a group of volunteers to deliver courses with us. And we have also employed or contracted with other trainers who are working in other recovery colleges to deliver specific courses to us. So one of the things I put forward a bid last year to get additional funding to expand the Recovery College, and was successful in getting a further £80,000 to add to the budget. So what we decided to do was with the volunteers, we had lost a couple of volunteers who were doing really well and then went on to get full-time work. And what we wanted to do was to offer people in that position the opportunity to come and work for the Recovery College in a paid position. So we've recruited 2 new recovery worker posts to be able to expand the offer of courses that are available. This service was actually set up, and within 2 weeks we were shut down because of COVID and couldn't operate in community venues. So we operated online, and then now we've moved to a hybrid model. And I've just put the link there at the bottom to the Recovery College information, which is actually on Wokingham Borough Council's website. So the courses that we are provided are categorised into 4 main groups, which provide students with the opportunity to focus on particular areas. One is well-being, so it supports a better understanding of your mental health, it teaches you skills for self-management, includes a support group and for those who hear voices, and a support group for carers of those with mental health needs. They also teach life skills on their courses, so it aims at increasing people's confidence, helping them tackle everyday issues in life. We have creative courses which help people explore their creative side, which many people find quite mindful and relaxing, and helps them deal with their mental health. So that's done through a variety of mediums. And then we have a next steps course for anyone wishing to explore moving on, and maybe going into general education or employment. So we would do that as well. One of the services I wasn't asked to, but I thought would be useful to let you know about, because it might be of interest for you going forward. But as I said, the community mental health team deal with people who have a severe and enduring mental illness, and the talking therapies provide for people with common mental health problems. So there is a gap in between the 2 sets of provision. So the mental health integrated community service is already up and running in Reading, and is now being rolled out in Wokingham, and we're recruiting to those posts. So it will fill the gap. So we offer an integrated primary care service to individuals who suffer from, this is for significant mental illness, so it's higher level of need than talking therapies would deal with, and needed, which is too complex for primary care services like IAPT. So they're developing strong working links to the voluntary sector, primary care services and local authorities to enable holistic and person-centred approach. These services will be linked around the primary care networks. There's an overview of the model there on the slide. So in Wokingham, they'll be linked with PCNs, local authority and voluntary sector, to aid scoping, planning and implementing, and aiming to support so we would be looking to sort of be operational by the end of January 2023. And I thought this might be a service that you might be interested in looking at in future. So I was also asked about the impact of COVID and access to services. So during the pandemic, we moved to remote working during COVID using video consultation, phone contact, and then we were still doing face-to-face when it was clinically appropriate. The memory clinic was the only service that I managed, which ceased ceased in the first wave only, but has since been up and running since then. We had some issues with having to accommodate some staff with various conditions who had to shield. We managed by controlling the environment in the clinics using social distancing, PPE. Staff were prioritised for vaccinations. Like I said, we had a rise in the number of psychotic illness in the first wave and a rise in referrals for depression and anxiety. And this has been brought about really by people being socially isolated, having been furloughed, losing jobs, experiencing bereavement, having physical health problems, where I don't know, surgery for hip replacements or various things were cancelled during the pandemic. But then we also had some evidence of some people declining to be seen because of the pandemic. The impact on the workforce at the peak of the COVID infection, it was impacted mostly between January and April 22. So in Wokingham, we had some redeployment of WBC staff, not from my services, but into a task force to support the work of the during COVID, sickness absence and etc. Berkshire Healthcare Trust prioritised staff in crisis and hospital services, so there was some redeployment from community services to bolster that up. What we have seen is staff leaving or taking early retirement and recruitment being difficult. So for example, in the community mental health team, there were a number of staff who were reaching retirement age who left or took slightly early retirement, but that's been seen across the trust as well. And it has left some holes in the CMHT where we have struggled to recruit, but slowly we are filling the gaps and are expecting new starters in December and January, which will be a huge help. COVID continues to be one of the highest reasons for sickness absence. Some staff are returning to work on WBC and BHFT sites, but we are currently working to a hybrid model, so we're seeing people on site but also continuing the online consultations because some people prefer that as well. So we are, Berkshire Healthcare Trust are offering face-to-face consultations with people now as a norm, but some people may decline, and if they do, we'll make other arrangements. So all the way through the pandemic, clinical psychology staff had been drawn in to provide staff support and access to psychological support for staff, which was extended to social care staff as well. Current rise in COVID, recently we've followed the guidance all the way through, but we have now been instructed to, when we're seeing somebody face to face in the clinic or we're doing a home visit, to return to mask wearing again. So that seems to be dropping. So anyway, yeah, so that's all I've got to present. So I'm happy to take questions, and as will Helen, who is also online.
And thank you very much, Christine, for the presentation. Do we have any questions, councillors? The idea was really to try and give us an overview of all these different services. I understand there's 40 odd services, so there's a lot going on. Do we want to take this away and digest it, or what do we want to do? Any questions for now? I'll hand over to you, Phil, then.
Right. Hi, Christine. Thank you very much for this information, which I did read before I came here, actually. But one of the questions I had was about the crisis resolution home treatment team. Is that available to anyone to call if they are in crisis, even if they've not experienced a crisis before?
I can answer that for you. It's Helen Williamson, the Divisional Director for Mental Health Services in the community. And thank you for inviting us here this evening. And yes, that is a line that anybody can call if they're in crisis. And also we encourage any of our patients that are on our waiting list to use that number as well. And so it's a way of managing alternative arrangements while they're waiting to be seen across some of our services.
And so that people are also redirected through NHS 111 to the crisis. So there's a direct line through NHS 111 should anybody call that and need the crisis team.
Thank you. That's really helpful. I need to look up that number. So that not for myself, but I need to have it to hand. There has been some discussion about the level of referrals to some of the services, including, for example, that dropped significantly during the pandemic. Have they returned to their previous levels, or is there still some work to be done to get people to refer to those services?
It's an ongoing process, really. It has increased somewhat, but not to what we thought it would. But the teams are just working quite hard around how we get that delivery of messages back out for that service to be used. But it is increasing, which we're glad to see, and we're also always seeking opportunities of how we could review that.
And one final one for me for now, because obviously there is a lot to digest. And there was a lot of discussion about the potential for a surge in a period, undefined period after COVID, in requirement for assistance with poor mental health. Have we decided that maybe that surge isn't going to materialise in the way that we initially thought, or are we still planning for that potentially to occur across the services?
I think it probably has. We have probably reached our peak, you know, but we are planning for another surge of COVID and potentially some flu over the winter period. So you know, we are expecting that, and we will manage towards that. So at the moment, it does look like that we are okay, but however, the aftermath of it, you know, services are very stretched, and in Wokingham, our community mental health teams are very stretched, and demand continues to be quite high. But what we are looking at is other ways of working and supporting those teams. And I think the new team that Chris described, our mixed team, and the ORS roles that will be rolled out into Wokingham, that should support care in primary care, and also bridging that gap between primary care and secondary care with those patients. So supporting the GPs out there and supporting patients in primary care and in the community, and trying to wrap more services around them in the community, rather than them deteriorating and needing that secondary care services with us.
Just a small technical point. Can Christine stop sharing a screen, please? Thank you.
Oh, sorry.
Any further questions, councillors?
Could I just ask Christine what SIs meant? Is it serious illnesses or serious incidents?
No, it's serious incidents. So it's sort of, for example, if there's a suicide, then there's a formal process of investigation, which is what that's referring to. It's led by the clinical directors.
Okay, and maybe one question from me at the end. We were talking to the GPs earlier on, and they were really encouraging the council to assist with, I would say, communication. Would that also assist your organisations if we could assist with communications?
Absolutely, and we've also got some comms support for our organisation, and in terms of the new services which out in Wokingham now, we've got a comms lead working on that and the comms that need to go out to the GPs. But absolutely, any support that we could get, it would be really quite helpful around our services and just wider information around what some of our services are. But we can get our comms lead to work that up and to share that more widely. That would be helpful.
Yeah, I think we need to have some internal conversations with the responsible people. But, you know, I think if we can try and help each other and work together a bit, we may be able to, you know, get better communications to our residents, which I think will help us all. But
absolutely.
Unless there's any further questions, I would like to say thank you very much, Helen. Thank you very much, Christine. And I wish you a good evening. Thank you.
Lovely. Thanks very much.
Thank you.
Good night.
Good night. I think it's Health Watch next, isn't it? Is Sarah there?
Yes. Hi, I'm
Oh,
here.
brilliant.
Yes.
Hi, Sarah.
Hi.
Thanks for joining us. I'd like to hand over to you if that's okay.
Yes, thank you, of course. Yeah, my colleague Alice is here as well, who's been appointed as our lead officer in Health Watch Wokingham Borough in the last month. So just to introduce Alice. I've put a short report on some of our key things from the last 5 or 6 weeks in the pack. So I won't go through that because obviously we're short of time. Basically, just to say that we've been hearing the same issues reported with the GPs today, very much aware of the issues around what people's expectations are when they phone their GP or 111 or whoever, and we're basically standing ready and waiting to support with comms when those come out. So that's something that's very much on our radar. And then also interesting with the ICB, there's a lot of work, and I think Health Watch was mentioned in that presentation as well. So there's lots of activity around the ICB that we're involved in. So those are a couple of the key things that have come through here that have come through with us as well. And I would just say the other one still on the radar is NHS dentists.
Yeah, we definitely agree with that point, I would say.
So yes, if anyone's got any questions.
Any questions for Health Watch? Beth.
Could I ask one about dentistry, it being very close to my heart with a broken back tooth? The dental service for residents has declined hugely since the beginning of COVID. It seems that a lot of NHS dentists have gone into private practice and have not been replaced because there are simply no replacements. What's the future for our residents of dentistry in the borough, and maybe even wider than that? What's the future for our children's health with dentistry?
I think it's part of the national conversation at the moment. I can't answer directly the question, but it's certainly something that is national. It's something that Health Watch England are looking at as well. It's something that our other Health Watch services have found. So I can't answer the question. I can do a bit more research. But yes, it's definitely not something that's just pertinent to Wokingham Borough. It's a much bigger issue than that.
Ingrid, do you want to add something to that?
It was just to let councillors know, I think Madeline will have the detail, but that we are hoping to have a specific HOSC committee meeting around dentistry with the new commissioning responsibilities moving from NHS England to the ICB. We do have the kind of named people at the ICB who will be responsible for dentistry services in Bob. So we're hoping to get them along to have a bigger and more in-depth conversation about dentistry services in Wokingham and across Bob in the coming months.
Thanks, Ingrid. Any further questions for Healthwatch? Phil?
Yeah, I just wanted to make a comment, Sarah, which is we're looking to see continued activity from Healthwatch. We discussed this previously. I'm really pleased to see Alice on board, so welcome, Alice. I hope this means that we will be able to have some better local focus, and the report that you've given us is great for the moment, and hopefully we can then start to look at some of you will be able to produce a report which will give us some detail on themes individually as we move forward, not in huge detail, but for us to understand what it is that you're coming across in your interaction with the general public.
Absolutely. That was just a one-page outline of some of the things that we've been picking up recently. We're moving forwards with staffing and things. As you know, it's, as I said last time, it's been difficult with the previous staff not transferring. But as you can see from the top of the report, our engagement is up 80% on the first quarter. So we're heading in the right direction. So as those themes come out and we start doing specific pieces of work, then we'll be able to provide fuller information on what the public are telling us.
Sorry, Alison, please go ahead.
Oh, hello again. At the last meeting, I asked about the board because that section of the website wasn't there, and you explained to me that you've got a different model and you have an advisory group. So I had a look on the website, and now it does say where it says board and you click on it, takes you to join our advisory group and says you're looking for people. But when I clicked on find out more, it just takes me to the 2018 report of the previous Healthwatch. So I just wondered if you've had any success yet recruiting people onto the advisory group.
Yes, I'll check out that link. I wasn't aware of that, so thank you. Yes, we have. We've got two members of the board so far. I think we may have distributed the paperwork to yourselves. I need to check that. Maybe if anyone can help us with advisory group recruitment. As I say, we've got two already, excellent local people. So yes, if you would like to see our role descriptions and things, we can provide those to you, and any suggestions and people that you think might be interested, please send them our way.
Yeah, I'm sure we can all do that. We're all very linked in and on with our local communities and our wards through Facebook. So do you mean just for us to generally ask people if anyone's interested rather than recommend individuals to you?
Both.
Both. Brilliant. Yep. Okay, will do.
Thank you.
I think we've run out of questions this week. I think all the meetings we've had, one after another, you've exhausted us. Perhaps we need a slightly less packed agenda next time. But I'd like to say thank you very much, Sarah and Alice, for coming tonight and providing your short written report, which is appreciated. And we look forward to seeing you again. Thank you very much.
Thank you.
Just a quick comment moving forward. Try not to be like death by PowerPoint. I know as chair, could you ask before the meeting that we don't just read out the PowerPoint? I know it's me being a misery, but you just lose. I just lose it in the, trying to engage with it when they're just reading it out. It'd be good if they got key things they wanted to pull out of that report, but some of it is a little bit. And it drags the meeting on. It's just an observation.
I do agree with you, Rebecca. I didn't realise she was going to present quite in that way. I think there's certain elements where she was responsible and she was giving us more meat on the bone, which was quite interesting. Other elements where she was presenting somebody else's slide, she was reading verbatim, and I take the point. Yeah, thanks for the feedback. So forward programme.
So for January's meeting, you've got autism strategy and NHS continuing healthcare was deferred from this meeting. I think they're both quite big items, so I would suggest where we've got a continent service, you might actually want to ask for information offline, and then kind of, because it was from an issue which was some time ago, just to see whether it was something that you still want a further update on rather than at a meeting.
Well, I think if they can be encouraged to present us with a report we all read in advance, and then we say, we've all read this, let's go straight to questions, we might be able to achieve more in our meetings, because there's quite a lot of important stuff we need to fit in. I would just say, have they confirmed the autism strategy and the continuing healthcare that they are definitely ready and going to attend?
Yes. And then, as Ingrid said earlier, we do have a extraordinary HOSC and scheduled for the 17th of January, specifically on dentistry. And is that, sorry, we have a meeting on the 17th of January, specifically on dentistry. Is there anything that members wanted to raise?
17th of January, yeah. I think it was on an email, wasn't it?
There has been an email, definitely, yeah.
I think this is a bit of a hangback, because we didn't really get, in my view, we didn't get a very good response previously on the dentistry topics. So the idea is that we've requested some further information. We're also getting different people presenting. I believe Mr. O'Keefe is going to present, but in addition to other people as well, because I don't think the answers to the questions previously from Mr. O'Keefe really satisfied this committee. So hopefully we get a better meeting on the 17th of January. So is that a problematic date? Is there anybody who's got a real problem with that? Okay, so we leave that in as is, I guess. We've got a lot for the 25th. Are we okay with that? Having, 5 topics in one meeting, is that too much? Yeah, I think it's a bit too much. I don't know whether we can shuffle that about a bit. I think 5 topics is too much. But, please tell me if you disagree.
That you got information offline regarding the continent service, and then decide whether that's something that you want to look at a future meeting, because the autism strategy and the continuing healthcare items were particularly weighty.
I think that's a good suggestion. Should we take that, committee? Yeah, I think we take that suggestion. Thank you very much for that. Any other business? Does anybody want to raise any other topics? Well, that's another reason why I said 5 looks a bit busy for January. Andy?
Yeah, just going back to my... Sorry, just going back to my earlier point, it's taken me about 3 minutes to find some social media comms that the borough put out this week last year, making exactly the same point that Dr. Sharma made. In fact, one of them is even a video of Dr. Sharma making the same point. So the idea that we need to wait for the borough to onboard a new health communication specialist is absurd, and I really do think you should communicate with our comms team and with whoever it takes, with Ingrid, today or tomorrow, to make sure they start getting this stuff out again if they're not already planning to do it. It's literally the only thing we can do, and we should be doing it.
Yeah, this is it.
Well, there's several posts.
Yeah. I mean, I don't know the mechanics of any of this yet, so I have to ask some questions. But I'm going to start that tomorrow. Not tonight, but tomorrow.
Just write. How about just write an email? I think everybody in the committee would support that. Just to try and set something in motion.
Yeah, it's 9:20. I need to chill out. I've got a busy day tomorrow. I've got a meeting every night this week, but I'm going to follow this up tomorrow during the daytime. I'm not going to leave it, Andy. I don't really appreciate that comment, Andy. I've agreed to take the action. I think that's reasonable and sensible. Does anybody disagree?
I don't think the excuse that you've got a meeting every night this week is something you needed to bring to this particular meeting. We've all got lots of meetings.
I honestly don't know what to say to that, Andy. Yeah. Yes, I think we need to close the meeting. Thank you very much, Andy.